Okay, so now we're going to talk about the short-term complications of diabetes, otherwise known as diabetes emergencies. You have now seen these. We talked about them last fall. So now let's come back and talk about what's going on and see if it clicks a little bit more. So first we'll talk about DKA, ketoacidosis. Ketones are formed as a byproduct of lipid breakdown. Remember, this is much more likely to happen in type 1 diabetes. Ketones are acidic, leading to metabolic acidosis. So what happens, we get acidotic because we have zero insulin. That means zero glucose getting into cells. That means we can try to break down proteins, or amino acids. That breaks down to more glucose that we still can't get in the cells. So we now try to break down lipids, which does work. It gives us a little bit of energy, but it also creates ketone bodies, which causes acidosis. So now we're acidotic. We have a metabolic acidosis. The respiratory system tries to compensate for that acidosis by getting rid of carbon dioxide. That's a different acid. That's called Kussmaul respirations. The kidneys attempt to compensate for that acidosis by buffering. Cells die without energy, and also remember that insulin helps keep the potassium in the cells where it belongs. So potassium goes into the bloodstream and then is excreted by the kidneys. The serum potassium is elevated, total potassium is depleted, and the patient is dehydrated because of polyuria. So that's what your patient looks like. They may come in seriously dangerous dehydration. What does it look like? Ketosis. So you may smell those ketones on their breath. It smells kind of like juicy fruit, or you may see ketones on that urine, on that UA. They're in a metabolic acidosis. They have Kussmaul respirations, ketone breath. They may have nausea, abdominal pain, vomiting. They're very dehydrated. What does dehydration look like? Decreased turgor, dry mucous membrane, sunken eyes, tachycardia, lethargy. They can go into a coma. However, remember that we look at urine output as a sign of dehydration, but if they have diabetes, if they have DKA, they're going to keep urinating. They may even have polyuria until they've depleted their water. Okay. So we can't just look at decreased urine output. If we wait for decreased urine output, they are critically dehydrated. They're going to probably have elevated to normal serum potassium. So it's going to be normal to elevated. They have positive urine ketones. They have elevated BUN and creatinine because of the dehydration, and this can lead to renal failure. Serum glucose will be over 300. So what is done to manage that? They need to be admitted to a unit where they can be closely managed. The highest priority is fluid. What's going to kill them first is the hydration. So the highest priority is to get fluids going. They need a really rapid assessment. They need a weight. If possible, we can compare it to their usual weight, but we also want to know as they put some weight back on, the weight's going to help us determine how dehydrated they are. They need a cardiac monitor because of the potassium, but their potassium is low in the cells, high in the bloodstream. We're getting ready to shift it back in. And so then they may move to low in the bloodstream, and all that potassium shifting around can cause arrhythmias. High or low potassium causes arrhythmias. So when we start moving it back and forth, they need to be on a cardiac monitor. Glucose and ketones can be checked at bedside. Some facilities don't allow ketones to be checked at bedside because of spilling. Labs, we're going to get venous glucose, electrolytes, BUN, ABGs, H&H, white blood cell count. Okay. Fluid replacement is the highest priority intervention. Have I said that enough? We really, really need to get fluids in them. Usually they start with normal saline and they try to replace the total fluid deficit over 36 to 48 hours. Insulin, they are likely going to be on a continuous IV infusion that is titrated based on blood glucose. So this is a titrated insulin drip. When you are mixing an insulin drip, it is absolutely critical that you put the the insulin into the bag before you prime the tubing. If I have a bag of normal saline, I prime the tubing. Think of how long a tubing is on a primary set, okay? And then I add a medication. And then I put that on a pump at 3 milliliters an hour. How long is it going to be before that medicine even gets to that patient? Okay, so we'll actually do that in class so that you can see. Making a note to remind myself to do that in class. We're going to look at that in class and see how long it takes. So you add the insulin to the bag before you prime the tubing. The other thing is that insulin tends to bind to that to the bag and to the tubing. So you actually lose even more of it. So it's even longer before it starts getting to the patient. Once blood glucose gets down to 250, 300, dextrose is added to the IV. Usually that's D5. And then those are titrated to gradually decrease the blood glucose. And they try to maintain it between 120 and 240 for a little bit. You don't want to bring it down to normal too quickly because that can cause symptoms of hypoglycemia. Electrolyte replacement. Remember, the serum potassium is going to be normal to high at admission, but once we get some fluids in and start insulin, that's going to cause the potassium to return to the cells, and so their potassium level in the serum will drop. They need to be on a continuous heart monitor. Potassium replacement starts when they're voiding at least 25 milliliters an hour and they're on insulin. They also look at the EKG, and then they want to start replacing that. They don't wait till it gets low. They wait until it gets back to the normal range and start replacing because it'll move into the cells fairly quickly. Okay, next section will be about HHNS.